Posterior dislocation of the hip. The head of the femur is pushed out of the acetabulum posteriorly in 50% of the cases due to a chip fracture of the posterior lip of the acetabulum, in which case it is called a fracture dislocation. Mechanism of injury. The injury is sustained by violence directed along the shaft of the femur with the hip flexed. This occurs in motor accidents. The occupant is thrown forwards and the knee strikes against the dashboard. The force is transmitted up the femoral shaft, resulting in posterior dislocation of the hip. Therefore, it is also known as the dashboard injury. Clinical features of posterior dislocation of the hip. The patient presents with a history of severe trauma followed by pain, swelling, and deformity. The deformity seen is flexion, adduction, and internal rotation. You can remember this by Fedi. Shortening of the leg is also seen. Thirdly, the head of the femur can be palpated in the gluteal region. Radiological features. The femoral head is out of the acetabulum. The lesser trochanter is not seen as the thigh is internally rotated. Shenton's line is broken. Treatment for the posterior dislocation of the hip. Reduction of the dislocated head is necessary since longer the head remains out, more chances of becoming avascular. The hip can be reduced by manipulation under general anesthesia. Open reduction may be required if closed reduction fails. Intra-articular loose fragment does not allow accurate reduction. Acetabular fragment is large and is from the weight-bearing part of the acetabulum. Technique of closed reduction of the hip. The patient is anesthetized and placed supine on the floor. An assistant grasps the pelvis firmly. The surgeon flexes the hip and the knee at right angle and exerts an axial pull. A sound of reduction is heard, after which it becomes possible to move the hip freely in all the directions. The leg is kept in a slight traction with the hip abducted for 3 weeks. After this, hip mobilization exercises are started. Complications of posterior dislocation of the hip. Injury to the sciatic nerve, since the sciatic nerve lies behind the posterior wall of the acetabulum. Treatment includes, since the injury is neuropraxic, it recovers spontaneously. If not reduced by closed method, open reduction of the fracture and nerve exploration may be required. If the sciatic nerve is severely damaged at this level, prognosis is poor. Avascular necrosis of the femoral head. These changes appear on X-ray generally 1 to 2 years after the injury. The avascular head appears dense and gradually collapses wholly or in part. Over a period of years, osteoarthritic changes become apparent clinically and radiologically. Osteoarthritis of the hip. It is a late complication and occurs many years after the injury. The cause may be avascular head or an incongruous acetabulum and femoral head. The initial treatment is conservative. In some cases, the operation may be necessary. Myositis ossificans. This occurs few weeks to months after the injury. The patient complains of persistent hip stiffness and pain. X-ray shows a mass of fluffy new bone around the hip. Treatment includes rest and analgesics.